and disadvantages. It's also going to hopefully give you a better idea and be better equipped to select the right study for your particular project or for your particular research question that you want answered along with your mentors. It will also give you an insight into how to be flexible and change study types or amend and tweak studies to satisfy your specific research question. And inevitably, many of you will have to do that. And I hope it will give you some confidence in using a variety of study types so that you can use them not just for the immediate 24 months, but really lifelong. Okay, so first question, why is it important? Well, it's important to choose the right study because ultimately it is one of the key factors that's going to determine what conclusions you're going to draw, i.e. the validity of your findings. It's also really important not only do you select it, but also you don't select the wrong study. And what I mean by that is, while we all would love to do double-blind randomized control trials that has $5 million of investment, the chances are that we're not going to be able to do that, certainly not in the next 12 months. It's also further important that you select the right study type so you don't reach false, erroneous conclusions and you don't become susceptible to bias. So what study types are there? Okay, so let's go through each one. There's essentially 4 main broad categories of study types, one of which is laboratory experimental. So this is what usually referred to as basic science, which I think is a bit of a bad term, to be honest, because there's not really anything basic about it. But ultimately what they mean is laboratory experiments and direct non-human studies. Then there's clinical experimental designs. And that's ultimately what a lot of us as clinicians, whether we're working in surgery or medicine or any other field, really do. And they mainly comprise of randomized control trials or non-randomized trials. Observational studies can be broadly categorized into descriptive and analytical, and there are subtypes of these as well. Literature-based ones are essentially when you are researching the literature to come up with a systematic review or meta-analysis to satisfy your research question. And I'll be talking about each one in turn and the pros and cons of each and when they would be appropriate and when maybe not so appropriate. So let's start off with basic science laboratory. As the name suggests, you're essentially going to be doing things like laboratory work, cells, tumor markers, genomics, tissues, animal models, experimental technology, medical devices, and it's usually in an established academic unit or established field. And Theo will know that the University of Oxford and Cambridge are both, which I've had the privilege to work in, have got a well-established history of developing genomics and medical devices. So what are the advantages of laboratory studies? Well, they're usually quite easier to replicate, and that's mainly because you can control many of the confounders and biases. They often result in high impact publications in big journals with big impact factors. You're also kind of pushing the frontiers of science, discovering a new protein or a way a tumor marker works or a cell signaler works. They can also be relatively quick, not always, but they can be quick depending on what kind of project you do. However, they do have their own drawbacks as well. For example, they can be essentially you're working in an artificial setting. So how applicable these findings will be to your clinical work, i.e. what we call validity in research, can be brought into question. So for example, just because you detect or find this particular cell marker in immunology or in cancer cell types, it doesn't necessarily always translate into clinical benefit. Excuse me. I know I said it can be quick, but equally the other side is it can be extremely time consuming. I mean, there are people and researchers who spend their entire lives looking at a single molecule. So there is a wide spectrum. It usually requires specialist equipment, specialist technology. It can be expensive, and you almost certainly will need specialist interpretation or a scientist to help you with this. So let's go on to experimental trials. And this was the second block that we want to talk about. Experimental trials are essentially broadly categorized into 2 main groups: randomized control trials, or RCTs as they're otherwise known, and non-randomized trials. And again, they both have their pros and cons. Experimental trials as we said, can be randomized or non-randomized. And this is the one that's quite directly applicable to clinical practice. You're essentially experimenting, for the want of a better word, even though I appreciate it has potentially negative connotations. You're experimenting on humans, i.e. you are creating an intervention. You are actively intervening in that person's and that patient's well-being or that person's treatment. And often the intervention is carried out in one arm compared to another. So you want to see for example, two different types of hip prosthesis when you're doing hip replacements, or laparoscopic versus open surgery, etc. And you get one group into one arm and one group into the other. What you're trying to establish through these kind of topics is these kind of studies is you're determining if the efficacy, i.e. how good one intervention is versus another, or versus a placebo or doing nothing. Now, as we talked about, there's two types: randomized controlled trials and non-randomized trials. Randomized controlled trials also have different phases, and there's usually in a lot of countries very strict legislation and very strict guidelines as to how to follow these phases. Phase one is usually a safety and dosage and side effect kind of study, where they take a small number of participants and they give them a dose of a drug, or they try a new technique or new technology on. They usually try on animal models first, and then this is like a first in humans type of study. Phase two is when you're trying to test the effectiveness and determine the further safety profile of this particular intervention, be it a drug or a technology or surgical procedure. Phase three is what you mostly have probably seen in publication. That's where you are pitting one treatment against the other. So surgery versus chemotherapy, or chemotherapy versus nothing, or whatever that may be. And phase four is really, once you've established that safety, efficacy, and its superiority to other treatments, you're looking for additional benefits and cost effectiveness. A little word about randomization. Now, I don't want to kind of encroach too much onto statistics and other things that may be covered by other presenters later on in these courses. However, there's many different types of randomization, but perhaps the three most commonly used ones are simple, block, and stratified. Excuse me. Simple being you just simply do a heads or tails, and you assign people to different arms. Block is when you do it by blocks of patients, and stratified is when you're looking at certain groups. So, for example, people of a certain age with having been assigned to one group or the other. Blinding. Another thing that randomized trials usually have is blinding. Blinding essentially means where one part of the experiment is unknown to either the patient or the experimenter. Now, unblinded is when you both the experimenter and the patient knows the treatment arm. So we recruit some patients and say, okay, we are going to be doing this treatment on you, and both myself as the experimenter and you as the patient know which pill you're having, which drug you're having, which treatment you're having. Single is when the experimenter knows. So, for example, in surgery, we often can't double blind because we have to do the operation. So we know what operation we're performing on a patient, but the patient may not necessarily know. Double blinded is when both of us, both the experimenter and the patient, doesn't know. And believe it or not, there is even triple blinding, where the experimenter, the patient, and the person recording the outcome, because the experimenter or the person doing the surgery, for example, may not necessarily be the person actually recording the findings. So, for example, we may do a certain laparoscopic technique whereby the experimenter may not know exactly what procedure that the patient has been in. The patient may not know, and the person who's actually looking for wound infection may not know if this patient had one particular experiment or the other, one arm or the other, excuse me. Okay, the pros and cons of randomized trials. Well, they're considered quite high levels of evidence. If we remember our hierarchy, and we'll talk about the hierarchy of evidence a bit later. They do tend to minimize confounders and biases. They can also explain cause and effect. So I did this to this patient, I gave them this drug, and this was the cause, and the effect was this. It is very good at obtaining that kind of cause and effect relationship. The populations are usually well defined. You're by selecting your patients carefully, you are looking at specific groups and you're further minimizing your bias. They can, however, or they are almost always expensive, very expensive. They can be very time consuming. I mean, I've been involved in a handful of trials, and just the recruitment process can take up to a year. Obtaining ethical approval before you even start the study, before you even do a pilot study, can be another year. So it is not unusual for trials to go on 2, 3, 4, 5, 10 years, especially those in cancer. When you're looking at 5-year survival and so on, you obviously have to allow enough time to elapse to know what the 5-year survival benefit is. We also adhere to strict ethical standards. And as we talked about, there are many countries have very strict legal and medical ethical protocols in place. Now, I know I said that because the population is well defined, but a downside of that can be because you have very strict inclusion-exclusion criteria, it can be too specific. So yes, you've done this wonderful trial and you found this in this particular group, but does it apply to people who are younger or older or male or female, etc.? They can also suffer from underpowering. What that means is a statistical term whereby you don't select enough patients or you don't recruit enough patients, and you end up not seeing the difference between the treatment arms, not because there isn't a genuine difference, but because you just haven't had enough observations, i.e. you haven't recruited enough people. Non-randomized trials, or non-randomized control studies, as they're otherwise called, where participants are not randomly assigned, but they're allocated based on clinical need or demographic characteristics. They're usually deemed to be slightly inferior to randomized control trials. However, in certain instances, it may be unethical to randomize people. Therefore, a non-randomized trial would be the next best thing. The pros and cons of this is, as we just mentioned, they can be used when it's not really possible or ethical to randomize people. It does allow examination of exposure and the outcome. So it does have some validity in terms of cause and effect. And it's also quite useful when the outcome is rare. So if you wanted to study a very rare, unique group of patients or treatment arm, you can use this kind of study design. They can, however, suffer from selection bias, which randomized control trials do not suffer from as readily. And the reason for that is you're obviously defining a preset group, and you've already made up your mind about which arm they're going to be in, and you're randomly allocating people. It also cannot adjust for all the potential confounders there may be. The other tendency is that these studies do have a tendency to overstate the benefit of one treatment over the other. So if you non-randomize, for example, if you put all the healthy, young, fit, athletic men and women in one group, and maybe the other group has got lots of comorbid, more elderly, more medically complicated patients, then you find, surprise, surprise, the group that you wanted the young people to be in have done better. Well, yeah, that's no surprise, right? And because of the strict inclusion-exclusion criteria, it can also be too specific. So that's trials. What about observational studies? Now, observational studies are perhaps what most of you will be doing, I imagine. Now, I'm not trying to discourage anyone from doing trials or other things or lab work, but unless you've got some kind of background in it or a setup already, it's going to be quite difficult to do those other studies in a short space of time. Observational studies, however, usually can be done in a relatively short space of time. They can be descriptive or analytical. You don't, in an observational study, you do not intervene in the patient's care. You're merely observing what's happened to that patient, i.e. the environment is not changed by you. We don't change the surroundings. Now, the two different types, broadly, descriptive and analytical, are a little bit different in the sense that descriptive is mainly you're just reporting a summary of what's happened. So 20% had this, 15% had that, using fractions, percentages, very simple statistics or no statistics at all, really. And you're describing what really is, what you just found. Analytical is a bit different. It requires statistical analysis. It's comparison between different groups. And this is very commonly used in surgical literature, certainly. Examples of descriptive studies are case studies, case series, and cross-sectional studies. Now, cross-sectional studies, you may see that I've got it in both groups. That's not really a typo. It can actually, it's one of those weird study types that can actually be in both, depending on whether you are just reporting percentages and reporting population figures. So, for example, in the UK, 1% of patients or 2% of patients suffer from diabetes, 20% from obesity, versus analytical, where you're actually comparing the different subgroups and getting statistical data. So it can be both. And more specific to analytical, you can have cohort and case control studies. And we'll talk a little bit more about each one as we go on. So the case, in the most commonly used descriptive studies are case reports or case series. So a case report is when you, as many of you know, it may be just reporting an interesting finding or case. And case series is when you've got many of those cases around an interesting concept or topic, and they're usually rare events that happen. So a handful of people have reported this very unique and rare event. Cross-sectional studies, like we said, could be you're reporting the findings in a population. So the population had X number of comorbidities or X number of complications. What are the pros and cons? Well, observational descriptive studies, they can be very quick and usually straightforward. So writing up a case report, case series can be done and very quickly because you have most of the tools ready to hand. And they can also be reflective of real life. This is something that has really happened. This is an observation that you've really seen in real life. So therefore, as we said, in the compared to the laboratory studies where we think it may not be so applicable to real life, observational studies, in contrast, are actually quite realistic because they're based on things that have happened. They usually incur next to no or very minimal financial costs, and they also need minimal expertise, if any at all. It also does not require detailed statistical analysis. What are the downsides? Well, they are often considered to be relatively low quality evidence. And there is a risk of bias and a risk of not being able to control for confounders and limitations. They cannot really readily demonstrate causality. So like we said in the randomized control trials, which are very good at demonstrating cause and effect, I gave you this drug, this is what happened to you. Observational studies can't really do that. They can only really demonstrate association. The results may, I mean, I know I said they're quite realistic to real life, but they're realistic to real life in a particular population and may not be applicable to a wider general population or between different countries or between different socioeconomic groups or ethnicities or different clinical practices. So how we do a surgical technique may differ may differ greatly from how China does it or other countries do it. So there can be a bit of variability, let's say. What about observational analytical? So this is the other side of the observational descriptive, when we said you're only describing what you see. The analytical side, you're actually comparing groups. And one such type is the cohort study, where you're observing a group of patients through time. And perhaps one of the most famous studies in this kind of group is when they established that cigarette smoking leads to lung cancer, for example. And this was a cohort of patients, a group of patients that were followed through time who didn't smoke and those who did smoke, and they compared the two. They didn't intervene, of course. It wasn't a trial. They didn't give people cigarettes. They just compared those that did smoke versus those that didn't. And over many years, they found that actually in the smokers, the rate of lung cancer was far, far higher than those who didn't. So that's an example of a very good cohort study that has actually changed, well, essentially the face of medicine. Case control studies is when you have a group of patients who undergo a particular treatment arm, and then you can use controls. So you have demographically similar patients, for the want of a better word, who are then not exposed to the disease or not exposed to that particular treatment. And you're seeing what the complication rates were between the two, or what other negative impacts or positive impacts the experimental kind of group had against the control group. Cross-sectional, as we said, they can be descriptive and also analytical. And you're in this kind of setting, when you're talking about analytical observational studies, cross-sectional studies, you are not just reporting the findings in a population, but you're also using statistical analysis to compare one part of that group to another. Okay, what are the pros and cons of observational analytical? Well, again, they can be like descriptive, they can be relatively quick, straightforward. They can also be reflective. They don't have many financial costs, if any, and the expertise required is minimal. And they also do something that the descriptive studies can't do, and that's allow reasonable comparisons between different groups and use statistics to prove a definitive difference between them if there is one. However, depending on how these observational analytical studies are performed, they can be considered low quality evidence if not performed well. And again, sometimes it can be impossible or difficult to limit the confounders or biases that may creep in. Once again, unlike randomized controlled trials, they cannot really demonstrate causality. They can only really demonstrate association. Once again, results are not always applicable to different populations in different parts of the world or different populations in the same society, but different demographics. That moves us on to really literature-based, which is perhaps in some ways the quickest and easiest things to do. And I know that from the slide that was shown by InciSioN at the beginning by the faculty, that there are already plans underway to undertake some systematic reviews and meta-analyses. So what is a systematic review? Well, broadly speaking, a systematic review is a collation of knowledge and information published in a specific area. You're searching the literature, you're gathering what's known about it, and you're presenting it and condensing it, summarizing it for a reader, so that that person, that clinician like yourself across the world doesn't have to sift through 50, 60, 100 articles to try and see, well, what's the gist of this topic? You know, what's the answer here? You have done the hard work for them, essentially. Now, in a systematic review without meta-analysis, i.e. a pure systematic review, you're not really performing any statistical analysis. You're just collating the results and saying something like 30% of patients had X across 15 studies, 23% had Y across these studies. There is also, within systematic reviews, there's also a subgroup of study type that's called review of guidelines, or even reviews of reviews. A review of reviews, which sounds almost comical, can actually be quite useful. What a review of review is, over time, the reviews will include more and more studies as more and more studies get published. So a review 10 years ago may be slightly out of date, and another one 5 years later is done, and so on, by somebody else. A review of review can take all these reviews and give a massive overall kind of picture of the findings. Now, the review of guidelines, and this is something I strongly urge some of you to consider because it's relatively easy to do, and it's quite topical, and it's quite a new study type that's crept in over the last 10, 15 years, is to review guidelines to see what the quality of guidelines are like in a particular topic. Now, you may think that all guidelines are excellent, but I assure you, as somebody who's reviewed several guidelines in different topics, I promise you it's not. There is a massive variation in the quality of guidelines between different societies that publish these guidelines. Some of them are absolutely fantastic, some of them not so good. How do we assess guidelines? Well, we can use something called the agree to, which if you get time, Google, and there's a very good video on it. It's a validated tool that's used to assess guidelines, and it will take you through how to do that. Okay, that brings us on to meta-analysis. Now, a meta-analysis cannot be done in isolation. Meta-analysis is essentially a statistical method. So in itself, it's not absolutely in itself a study type on its own. It's really incorporated into a systematic review. So you can have a systematic review alone, or you can have a systematic review with meta-analysis. Meta-analysis is statistical analysis of the published data. So like we said, in a systematic review, where you're only reporting the 36% versus the 23% had this or X or Y, in a meta-analysis, you're actually using unique statistical tools to kind of merge and mush all that data together to produce a new data set. So a new odds ratio, a new percentage, or a new confidence interval. And the advantage of the meta-analysis is you can compare different groups with a p-value and reliably. What are the pros and cons of systematic reviews with or without meta-analyses? Well, they can be very, very quick and straightforward because it's largely in your hands. You don't have to go around recruiting patients. You don't have to spend weeks and months in the lab. You just search the literature, you define what you want to look at, the question that's important to you, you pull the relevant articles, and you start analyzing them in a meta-analysis or just reporting them in a systematic review. They can be considered very high-level evidence. For example, those systematic reviews and meta-analyses of randomized controlled trials in particular are deemed the highest level of evidence, because what you're doing there is you're saying, right, there's been 10, 15 randomized controlled trials in this particular field on this particular specific question, and they may all, say slightly different things. Well, what do they say overall? And the only way really to determine that is to do a meta-analysis, whereby you're taking all the data from all the randomized controlled trials that have been published to come up with an overall result. Apologies for background noise. It doesn't require any financial cost. It doesn't incur any cost or planning, or very minimal planning. In a systematic review, you don't really need any statistical experience if it's just a systematic review. And it usually is very, I hate saying this word, but it's usually publishable. And what we mean by that is it tends to get published. Systematic reviews are quite well sought after if conducted properly. And that brings us on to the cons, really. They can be performed quite poorly, and they can introduce a lot of biases depending on how you perform the systematic review. Now, the purpose of this talk isn't really to encroach on other lessons and lectures that you may have, where we talk about how to actually conduct the study. So I'm going to be careful not to go too much into that, because that will come later on. But ultimately, you've got to be very clear and have a very set criteria as to what papers you're going to include and exclude and why you're doing them, and have a very good clinical reason to doing so. Otherwise, you are at risk of introducing considerable bias in your results. Obviously, if you have 20 papers published in this particular field, and you only select 3 of them for whatever reason, you better have a good reason. Otherwise, what about the other 17? Is it really valid to reach a certain conclusion based on these 3 and exclude all the other 17? You may have a very good reason for excluding the other 17, but you've got to be clear why that is. Results are therefore very dependent on what the paper is and what papers are and what papers aren't included. Meta-analysis itself does require specific statistical knowledge. It is not terribly difficult, to be honest, but it does need some training. There's some very good YouTube videos. There's a software actually called RevMan. There's many different softwares you can use, but there's a free one called RevMan 5, which you can download for Mac or PC. And there are YouTube lectures and YouTube videos that can show you how to do that and how to use it. It's actually pretty easy to use. And even though the statistics may seem daunting, it actually makes it very easy. But you have, of course, got to be able to interpret those statistics. So for most people, meta-analyses do require a bit of help from somebody a bit more experienced. Okay, levels of evidence we talked about. Systematic reviews and meta-analyses are actually considered to be pretty high in the level of evidence, especially if they're randomized controlled trials. Below that, it's single randomized controlled trials and cohort studies, case control, case report. Perhaps the most, or the weakest rather, of the levels of evidence is expert opinion, background information, and kind of non-systematic reviews. So just narratives and chapters and things. So you may be thinking, well, okay, you told me about all these different study types, and how do I actually get to choose them? It can be quite difficult to choose. I have a specific clinical question in mind. Which one do I pick? Well, the first thing I would want to say is you've got to consider some factors. First of all, time is really, really important. Be very realistic. I'm not trying to downplay anybody's hopes. Far be it from me to discourage anyone, as I hope Theo can testify. I'd like to encourage people in research and in clinical work and in education, but expecting that you're going to just smash out a randomized control trial in 6 months is just unrealistic. You're going to be bitterly disappointed. So just think, how much time do I have on this? How much time do I want to spend on this? When do I want to publish it by? But also, you also need to have an understanding of how much experience you've got, and don't be disheartened that your first 1, 2, 3, 5, 10 papers or studies may not be randomized trials or really high level evidence or really big studies involving 15,000 patients. Mine certainly weren't. just remember, you got to take in steps. And as you get more experience, more confident, you can do bigger and bigger things. Think about your resources. You know, if you really want to do a lab study, but you're in a place where you haven't got access to labs, you haven't got access to the scientists that you need or the equipment that you need, and you don't really understand the science behind it, or you can't recruit patients to a study, it's very difficult to perform that study. Please, please, please choose your collaborators carefully. And the thing is, once you start saying, I want to do a study, every single person in the world wants to do a study with you, but just be not selfish, but be a little bit selective. Make sure that your team is broad, make sure they've got a mixed skill set. So you may have somebody that's good at statistics, somebody who's good at paper writing, somebody's really good at data analysis and data gathering, somebody else may be very good at recruiting or have access to labs or so on. Whatever your study type is, just make sure that everybody in that team is doing something. And that something may mean somebody experienced, one of your professors or one of your senior clinicians, consultants, or whoever with many years of experience who may be able to give you advice. That in itself can be very important. Consider whether you need to do statistical analysis, whether you could do them yourself, you can learn them yourself, and there is a learning curve. It's not quite as daunting, as complicated as people think, but there is definitely a learning curve. And unfortunately, certainly in the UK, that's not something that we're readily taught. But if you don't feel that this is something you can learn or want to learn, you can still do studies that have got that require statistical analysis. You just need to be able to access that. Be very clear as to how important this work is. Now, we all, when we start off, think that the project we're doing is the most important project above all the other Nobel Prizes, but in reality, unfortunately, that's probably not the case. So be optimistic, be confident, be motivated, be excited, but equally just temper what you want to do. You know, as I would love for all of you to discover the cure to cancer and HIV and God knows what else. But the reality is that unfortunately, very few of us, if any of us, are going to be able to do that. So be a little bit realistic. So ask yourself, what question do I want to answer? Why do I want to answer this question? Is this a worthwhile question? Is it of any importance clinically? Now, you're all, I think, clinicians. So, you know, is this going to really add to the literature? And then importantly, when you come to select your study, okay, if I want to test how good this pill is against the other one, well, I probably need a randomized control trial, and doing a case series is probably not going to answer that question. So will my study that I've selected actually answer that question? And this is where your more experienced collaborators, your mentors come in. Have an understanding and be aware of the knowledge and literature that's published already. If somebody has already done a systematic review and meta-analysis of 50 papers on a particular topic in plastic surgery or general surgery, ENT or whatever, just 2 months ago or last year, what are the chances that your paper doing this exact same thing is going to be published? It probably won't. So don't waste your time doing something that's already recently been done. And this is particularly important in systematic reviews and meta-analysis. Don't choose a topic that's been done to death or has been done very recently where there's been no real added extra papers. Now, it's different if the last systematic review was several years ago, and since then 7 or 8 other papers have come to the literature, then you can do an updated systematic review. That's perfectly acceptable, but don't do something that's already been done before. So how can we choose? It can be quite difficult, but hopefully this will make it a little bit more clear. You essentially want to know, first of all, are you going to intervene? If you're going to intervene in the patient's care, well, you're going to have to do an experimental study. And then you're going to have to think about, am I going to randomly assess, you're going to do an RCT, are you going to do a randomized control trial, or are you going to do a non-randomized trial? Now, without giving anybody's hopes up or being negative, and it really isn't my intention, the chances are that many of you will not be starting off with this kind of experimental study. Many of you will probably be doing observational studies. And then you got to think, well, am I comparing 2 different groups? Am I comparing diabetics versus non-diabetics and comparing what their wound infection rates are after appendectomy or surgery or whatever? If the answer is no, then you just need a descriptive study. If your answer is yes, I want to analyze and say, is there a statistical difference between these 2 groups, or the group that had antibiotics and the group that didn't, then you need an analytical study. So this is an observational study that's analytical. And then you got to think about, well, what's the direct exposure? You know, is it exposure and outcome, or in which case it's a cohort study? So that's the lung cancer and cigarette thing we talked about. You don't get lung cancer first, you smoke first, and then you get lung cancer. So the exposure is first, and then the outcome is later on. And that's why you get a cohort of people, you follow them through many months, years, decades sometimes. And that's a cohort study. If, however, the event has already happened, and you're just observing to see why it happened, or what are the things that make one group more or less likely to happen to, then you are looking back in time. So you've already know the outcome, you're just looking back at the exposure, and that's a case-controlled study. If, however, you're doing a cross-sectional study where you just want to say, right now, how many people in the UK eat lots of biscuits, chocolates, and snacks, and they're obese? That's an exposure and outcomes happening at the same time. And you would use a cross-sectional study. And this is just another way of kind of looking at it. So does it contain an exposure? Does it intervention? And that would be a trial. If no, observational study. And this is just another way of looking at it. Essentially the same slide as the last one. So what are the common pitfalls? I'm just going to wrap up now because I want to leave some time for questions. Some of the common pitfalls are these. And I see this a lot in people who approach our research collaborative, and certainly during my training and my research time, is people who have got very poorly designed studies, or that don't really answer their question. So they want to answer a specific question, but what they've selected is very far from that, or they have a very unrealistic understanding of timelines and funding. Whatever paper you send to a journal now, I promise you, it's going to take at the minimum 3 to 6 months before it gets published. And that's after you've done the paper, after you've done a study and written the paper. So you can imagine what the turnaround time is like when you're starting from scratch. There's also a tendency for clinicians to be either very overconfident in what they can achieve or underconfident. So the overconfidence being, well, yeah, I can do all this. I can do a systematic review, meta-analysis of 150 papers, and I'll do it by next weekend. It's not going to work. I've obviously been using a slightly exaggerated or very exaggerated example there, but this does happen, believe it or not. Or they can be very underconfident. So what I mean by that is they think, well, actually, I can't really do an observation study. I don't know the statistics. Nobody can help me with this. And they settle for a much smaller study when they could have actually done something more impactful. Collecting too many or too few variables is a real problem, especially you having to collect the data yourself in observational studies. I've seen people come up with Excel spreadsheets when they want to do a study, and for each patient, they're collecting 100 different variables. I mean, that's just insane. It's going to take you years to do that. Restrict yourself to the number of variables that you really need to answer that question and ignore the rest. Don't just collect data because it's nice, because it'd be nice to have more data because then we can look at this, and that, and have 11 objectives. No, 2 or 3 focused objectives is far better than having a very broad, wishy-washy paper where you're not really sure what's going on. And running out of steam and momentum is unfortunately a common problem as well. And that's usually because people are doing too big a project or they're not engaging enough time with it. And everybody gets excited the first few weeks, say, yeah, let's do a paper, let's do a study. And then a few weeks down the line, nothing's really moved on and people start fizzling out, people start dropping out. Before you know it, 7 months elapsed and you haven't actually done anything. Don't overthink things. You can do this, believe me. Nobody's born with this knowledge. I certainly wasn't. I didn't have any undergraduate training in this. I'm certainly not the brightest person in this webinar. I can promise you that. It doesn't take exceptional human beings to do this. All of you can do this, so don't overthink it. But equally, just have a clear question, speak to your collaborators and your mentors, and have a specific goal and timeline. So what should you aim for? You want a manageable project, i.e. an observational systematic review, unless you've already got a lab or trial set up, then in which case, please crack on. I'd love to read your paper. But otherwise, use an observational study or a systematic review as your first couple of studies. Start early, be confident, but also realistic of timelines and what you can achieve. Search the literature. Who's done this? Who's looked into this? Am I replicating something that somebody's already done? If that's the case, there's not much point because you're going to have difficulty publishing it. What you don't want is spend 1.5 years on a project. You've written a nice manuscript. You've given up your weekends to do it, and then it can't be published. Find a topic that interests you or is clinically important or relevant. You know, think, how important is this? Is this really a clinical problem? Are people going to be interested in reading this? And that's where your mentors and your supervisors can help you with, because they're going to have more experience in the field. Do a little every week, like anything else. Do a bit every week or every other week. It's impossible to do a bit every day because we all have lives outside of medicine. We have on calls, clinical commitments. We've got to learn how to operate, treat patients, etc. So it's not realistic to think you're going to do a bit every day, but certainly you can do a bit every week, even if it's just 1 hour. Keep that momentum going. Don't run out of steam. Limit your variables. Please, please, please don't collect 100 variables. And then when it comes to the analysis, you only use 7. What's the point? You've just wasted all that energy and time. So that's all I'm going to say about that. I've limited it to the study types and what you should do, rather than talk about how you're going to do it, because that's really a topic for a different area that's going to be covered. Now, without kind of overstepping into what the mentor scheme, which I think is a fantastic scheme that InciSioN set up. In fact, all of InciSioN I think is phenomenal, and I really applaud the faculty and yourselves for taking part in this. I have limited it to what the study types are and where they're useful and where they're not. Not how to actually execute them. That's for later on. So I hope you've all found that useful. I can see in the chat there's been some, I believe, some questions. I'm more than happy to answer any questions now. And there's no such thing as a question that's a little bit too basic, or that please don't feel embarrassed. Please do ask questions. Please do contact me. That's my Twitter handle at the top, and that's my email, personal email. More than happy to talk to anyone. I don't want to overstep the mentee and mentor relationship, because most of you will have mentors yourselves. I'm more than happy to take on one mentee. In fact, I've got one assigned, but equally, we don't really want every mentor to have 20, 30 mentees, because we can't allocate enough time that you deserve for your projects to come to fruition. So I'm going to leave that there now, and I'll be more than happy to take any questions that anybody has. Thank you.
Yes, please, I have a question.
Please.
Please, can you go over the cross-sectional study being both descriptive and analytical? Can you go over that again?
Okay, so a descriptive study, on the face of it, it sounds very much the same, descriptive, but there is a distinct difference. In a descriptive study, you are just giving percentages. You're not performing statistical analysis. So 10% had a wound infection, 10% of those with diabetes had wound infection, but only 7% of those who didn't have diabetes had a wound infection. Well, is that true? Is that statistically relevant? Is that statistically right? Could this have happened by chance? It just so happened that 10% of those diabetics in your particular study of 100, 200 people had higher wound infections. But if I take another group, maybe the wound infections are exactly the same. That's descriptive. Now, a descriptive can't tell you that because you don't perform statistical analysis. However, when you become analytical, you're actually subjecting the data to statistical analysis. Thereby, you can demonstrate actually this result hasn't been obtained by chance. We have performed statistical analysis, and yes, truly, patients with diabetes do have a higher wound infection rate than somebody who hasn't got diabetes. Does that make sense? The difference is really in the statistics. In a descriptive, you're just reporting percentages without performing statistical analysis on them. In the analytical, you're performing specific statistical analysis to compare different groups. Does that answer your question?
Yes. That answers it. Thank you very much.
Not at all.
Dorcas, are you happy to take the questions on the chat and then just ask?
Okay. So we have a question from Jonathan via. He says, will I be right if I say some study designs, for example, case reports, and can help identify a research question?
Yeah, absolutely. So that's called a hypothesis generating study. It is, and it's not a specific just study in itself. That can be applied to many. That term can be applied to many different studies. Essentially, that's a very good question. Essentially, what you're doing is you've got a series of cases, and you're thinking, well, actually, I'm seeing a bit of a pattern here. This could lead me on to do an observational study whereby I look back in the last 10 years, for example, in my institution's data or multiple institution data, and say, and look at, see if there's a true difference. I've looked at these 20 cases and they all seem to have a slight pattern here. Does this pattern hold true when I do a bigger observational study? And the answer is yes, absolutely. You can use a case series or case reports, a series of case reports to generate an interesting question, and then you can follow that up with a bigger, wide observational study.
Thank you. The second question is, as a novice in research, how can I do case reporting?
I'm sorry, I didn't catch that last bit. How can
As a novice in research, how can I do case reporting?
How do you know what's important?
Yeah, how can you do it? Like, how can you, undertake a case report? Or a case report?
I'm sorry, is the question, how do you know if a study is worthwhile doing and important? Is that the question?
I don't know. Jonathan, are you online? If you could
Can you
share more
clarify
light.
that for us? Sorry, I just want to make sure I'm getting the right answer to you.
I think Jonathan is asking, he is a novice in research. He wants to undertake a case report. How does he go about it?
Oh, thank you very much for that. Okay, so a case report is relatively straightforward, actually. So don't worry too much about that. And certainly one of my kind of early studies was exactly that, a case report. A case report is where you find an interesting case. So something that's very unusual. And what you do is you describe, now in many countries, certainly in the UK, you need the patient's permission to do this. So even though you're not going to name the patient, you still need some kind of permission from them to publish in the literature. What you do is you take that patient's story, so their lab results, their white blood cells count or whatever lab results you have, the CT or MRI findings or ultrasound X-ray findings, whatever that may be. And then you describe what happened. We had a 37-year-old male who came in with this thing, and it's very unique, rare, and weird. That hasn't really been reported much in the literature. And then you describe it, and you then in a discussion section, you talk about what other people have reported, similar cases or different cases. Now, a case report is a good one to start off with, but it is still considered relatively low quality evidence because you are essentially basing all your opinions on the one case. It's one person, it's one event that's happened. You know, you can't really apply that to a much wider population, but it's not a bad one to start off with. The only thing I would say is not every journal will take case reports. There are some journals that will, some that won't, and there are actually journals that will specifically take case reports, but that's definitely not a bad one to start off with. The first thing you need to do is find an interesting case that's not very typical, and then gather the story, the labs, the images, and so on, and start writing it up. I don't want to go too much into how to do these studies because, like I say, that will be covered in a different topic, and certainly we can't cover all of that in 1 hour session, unfortunately. But that is briefly, that's how you do it.
So there's also a question from Robert Gaba. He's asking, so let's say I've picked a research question, but it's already been published, but also looking at the publication, it seems old and the statistics doesn't correspond to the current statistics. Hence, that research doesn't answer the same question in the contemporary era. Can I go on to do my research?
Excellent question. Very good question. Yes, of course, times change all the time. New techniques, new drugs, new ways of practicing medicine, new imaging techniques happens all the time. So that is perfectly permissible. So for a study was done 40 years ago using X-rays, and now you've got, a high resolution CT scan or a 4 Tesla MRI scanner, then of course that would be perfectly valid. So the answer is absolutely yes, if there's enough of a difference. Now, you can replicate observational studies. You can say, well, some people have found this, we found something different and we think the reason may be this. So you can do that. It doesn't have to be completely unique, but it has to be different enough in terms of at least your outcomes. I mean, your outcomes can be similar, but you should be looking at something slightly different as well. Basically, it's a fine line between having something that is unique enough that will get published that a reader will find interesting, not, oh, I've seen this type of study 50 different times with exactly the same results. What's the point? Because you won't get it published. But equally, you don't want something that's so crazy, unique, and different that you think people think, well, what are you talking about? This goes against all of science. But yes, you can.
Okay, so we have a last question from Barawusu. How do retrospective cohort studies differ from case control studies? How does retrospective cohort studies differ from case control studies?
Okay, a retrospective cohort from what, sorry?
Retrospective cohort studies differ from case control studies.
That's a good question. In a cohort study, usually you are following one population through time if it's retrospectively. So what we mean by that is you've got a group of patients where you already know the outcome. You know who got lung cancer from their smoking, and you're going back in time to see what some of the factors were that contributed to that. A case control study is one group hasn't actually had the exposure. So, and you're comparing they can be, and you're comparing the two groups. They can be very similar. I mean, it doesn't really matter which one you do. What's more important, I mean, your findings are going to be very similar. The statistics that you use are not going to be very different. What's more important is my question going to be answered by this kind of method, i.e. just observing these two groups and comparing them? That's more important. So don't get too bogged down. Is this really a case control, a retrospective cohort, or a case control study? It doesn't really matter, because you're essentially comparing one group against the other. It's just the exposure and non-exposure group slightly different. The cohort study usually is that you've chosen a big group of people as a sample, whereas the case control is you've got those who've been exposed, and then you're selectively choosing your controls. So there's a slight difference. Whereas the cohort is you've already included everyone in there. But ultimately, don't worry about that too much. You can use either.
I think that's the last question.
Okay, thank you very much. There's been a lot of questions, I think, in the chat, I think some of which we have covered. But look, if there is, you have my email there, and I will put it in the chat as well. If anybody wants to email me for a bit more information or anything they want to talk about, I'm more than happy to. It's always difficult answering everything in one sitting. Somebody's got their hand up. I don't know, as admin, if you've got time or not.
I think we can take one more question. Whoever's hand is up can just ask the question now in the next 5 seconds. Otherwise,
I'll keep it very short. Please go ahead.
Kwakwege?
No.
Okay. I think the 5 seconds is up. Marian Harrison, if you're on the line, please.
Hi.
Hello.
Hello.
Yeah, Marian, we can hear you.
Hi, good evening, ladies and gentlemen. My name is Marian Harrison, and I hope you've all enjoyed the very informative session we've had this evening. And most importantly, I hope you've learned about the various study designs available to us as we progress through our research journey. Dr. Askari, thank you so much for the nuggets of knowledge you shared with us this evening. In a world of blind people, when it comes to research, which most of us are, it is quite comforting to have an expert hold our hands through this. And I do believe there was none more qualified to excellently dissect this topic than you. Thank you so much for spending time with us this evening. You just finished an on-call, and yet you still took the time to join us. We do appreciate your presence. Thank you so much.
Absolute pleasure. Thank you for having me. It's a real honor.
To the organizing committee headed by Dr. Kiflias Anyoni and Dr. Dakas Osei Opoku, thank you for the immense work and unpaid hours you've put in to make today's webinar. And by extension, the InciSioN Research Mentorship Program a success. You could have channeled your time and energy to do anything else, but you chose to impact young doctors. Thank you so much. We do appreciate you. To the leadership of InciSioN Global, our parent organization, thank you so much for your support. And to you, ladies and gentlemen, you've been a wonderful and engaging audience. Without you, this program wouldn't be as impactful as we hope for it to be. Thank you for being here tonight. We hope you've benefited immensely from this webinar. And we hope to see you in our next session next month. Thank you once again and have a pleasant evening.
Yes, and just a couple more things. Thank you very much. Marian is one of the organizing committee members. Thank you to the committee members as well. Anita, John, everyone on the committee. Very grateful for your time. Dr. Bando, there are a lot of you, I can't mention everyone's name, but thank you all very much for taking the time. Marie, I just want to say, for those on the systematic track and then the one-to-one mentorship group, you'll receive further instructions via email as to what to do. And we'll be adding you all to specific pages very soon. So just have a look out for that. And Alan, thank you very much. Thank you very much for taking the time.
Absolutely.
And Dorcas, if there's anything else you want to just let people know. If you've dropped your email in the chat, we'll send you a link to the recording. If you actually signed up with the registration link, then you don't need to bother, we'll send it to you. And those who came for the last meeting, will send you a copy of the recording. Thank you all very much, and have a nice evening.